Yeah, so I'll be talking about some basics regarding phakic IOLs because I use ICL. That is why I'm concentrating basically on ICL. I am well aware of the properties and the way the lens behaves. That is why this talk is titled Basics of ICL Surgery. But most of the tenets are applicable to any form of phakic IOLs that can be implanted in the posterior chamber. So whenever we try to put a phakic IOL in the posterior chamber, the first and the basic fact that we should remember is that it's usually done in a very young patient with a very healthy eye, and the only requirement of the patient being that they want to get rid of their glasses, and they cannot do it by an external procedure. That's why they've gone in for an intraocular procedure. So the first thing to follow is take care of the cornea and take care of the lens, the natural lens and the cornea of the eye. So the most important aspect is that the lens should be biocompatible. The least possible incision should be used to insert the lens. It should be non-traumatic when it's being maneuvered, because we know that the structures inside the eye are very delicate, very soft and susceptible to damage. So with minimal maneuvering and with such a lens that is very pliable and adjustable to the structures around it is what would be best for the eye. It has to be very thin because the placement is in the posterior chamber, and we know that unlike the anterior chamber, the space in the posterior chamber is very limited. It has to incorporate a wide refractive range so that it can be done for patients in whom LASIK may not be an acceptable form of treatment. And at the same time, with all these properties and incorporation of power, it should be non-brittle, so that once you want to remove it, it can be done even how long after the procedure of insertion you want to remove it. It should be non-brittle. It should not have changed its physical properties. So the lens I'm talking about, the implantable Kollam lens, is made of the material called Kollam, which is a combination of collagen as well as HEMA, hydroxyethyl methyl acrylate. So it's a copolymer of these two compounds. And the property which makes it so biocompatible, it can basically be divided into two parts. One is that it has excellent transmissibility of light and very low reflectance, so that glare and such other optical aberrations are prevented. And like we told earlier, it's very flexible in the anterior chamber, and the property of the material is such that a wide range of powers can be lathed into the lens. The other part is that this particular polymer called Kollam, the combination of porcine collagen and HEMA, methyl acrylate, is such a compound that it forms a biofilm around it and keeps itself segregated in the anterior chamber, so that the body does not recognize it as a foreign body. And when the eye recognizes it as a foreign body is when reactions happen. So that is an intrinsic property of this copolymer. Now, what are the most important aspects we should consider besides the compatibility of the patient? So what are the indications, to be precise? Indications, it is not as if you do ICL only for patients that have not undergone or are incapable of undergoing LASIK. ICL can also be done as a primary surgery because it doesn't drastically alter the shape of the cornea. It's not taking anything out or changing physiologically any part of the eye. It is also a procedure in case patient wants something, they are not very sure, they want it reversed after some time. So for all these aspects, ICL can sometimes be done as a primary procedure also, though it's always ingrained into our minds that it is in lieu of LASIK. In lieu of LASIK, it can be done when the power is widely outside the range of LASIK, Or if you do LASIK, you tend to end up with a very thin cornea or a very flat cornea. In either cases, you'd prefer to go in for an ICL. So the measurements that are required when you implant an ICL, one of the basic measurements is the anterior chamber depth. Another one is the white to white diameter of the cornea. Besides the power calculations, the keratometry values, the pachymetry, all these that we routinely take for any refractive surgery case, these factors are very essential for an implantable Kollam lens. So you can see that the white to white here is measured using the A-scan, and please remember that all biometers actually give you two values. One is from the epithelium, the other is from the endothelium. It is the value from the endothelium that needs to be taken. So if you have a biometer that is giving you the total anterior chamber depth, then the depth from the endothelium, that is subtracting the pachymetry, is the one that is used for calculation. The white to white measurement is done using a digital caliper. There are multiple ways of doing it. The company accepts two methods. One is using the OpScan, the other is using the digital caliper. This is a very, very small vernier caliper, and it is used under the microscope with the patient in the supine position, and clear cornea to clear cornea is taken as the measurement. So you know that limbus is not a single line, but it's a spread out area. So you have a corneal part of the limbus, a scleral part of the limbus. There's some pigment all around. So you need to take it from the limit of clear cornea to clear cornea at the widest diameter, which is done best under the microscope with the patient in the supine position. Now, the IOL has a plate haptic design with foot plates. It has a forward vault, and it also has some holes for aqueous drainage. So that is the lens I'm talking about. It has a natural forward vault. It has a central optic, which is a round structure. It varies in thickness between 50 to 150 microns, and the plate haptics, which go into the sulcus, and those are thicker than the optic. So again here, before I forget, never touch the optic of the lens with any instrument is another thing that is also to be followed. So this is how it sits in the anterior chamber with a 200 to 800 micron vault, which is considered ideal. Now, these are the diameters of the optic diameter of the lens, the sizes of the lens, and the extent of power that can be corrected. So please remember that even an ICL can correct only up to minus 18 diopters of sphere. You can add a 2 diopter cylinder to that as well, but not more than that. So if you have a patient who has 20 or 22 diopters, it may not be possible to fully correct that patient. Maybe you need to exercise some amount of bioptics over there, where you put in an ICL and then fine-tune using LASIK. So the sizes of the lens are the one that needs to be used in the patient are determined depending on what kind of an anterior chamber depth and white to white diameter the patient has. So it comes in various sizes all the way from, you have 12.1 to 13.6 millimeters. And for hypermetropia, the sizes are slightly lesser than what you have for myopia. So the first thing is that when you start implanting the lens, viscoelastic in the anterior chamber should be put in moderation. A 3 millimeter incision is usually used, and the viscoelastic that enters the anterior chamber should not stuff it. Instead, you should be able to see the lines of the viscoelastic as it comes out. Most of the surgeons prefer HPMC. Some even advocate thicker viscoelastics, but HPMC is basically preferred because it does not form a biofilm between the natural lens and the ICL, which some other viscoelastics may or have been reported to form. So that's the basic reason why HPMC is used. The people who are in favor of other viscoelastics, thicker ones like chondroitin or sodium hyaluronate, they claim that's easier to wash out of the anterior chamber, and remainder any residue may be more friendly, bio-friendly to the eye, but there definitely have been cases where biofilms had formed between the natural lens and ICL, because of which HPNC is preferred. So as I mentioned before, the incision is 3 millimeters. Now this is how you load the lens. The lens comes in distilled water nowadays. Earlier it used to come in saline. Now it has to be pulled through the cartridge, and sometimes the best way would be to push the cartridge back as you're holding the lens so that the lens slides more smoothly. So it's an extremely thin but pliable lens. So this is how you load the cartridge, and there's a soft tipped injector there which gently pushes the lens to the tip before injection. So this keeps the lens ready. Earlier you needed to keep this whole apparatus after loading in saline. Now that is not required because the lens itself comes in distilled water. The injection of the lens is done very slowly. Now this is not a wound guided injection like you do for IQ. This, on the other hand, the injector should be well inside the anterior chamber, and the lens is slowly passed and slowly made to open so that you're sure that it's aligned in the correct manner before it unfolds completely. The good thing about the lens is till you inject 7/8 of the lens into the anterior chamber, you can always flip it or turn it or do whatever you want to make it align correctly. So please inject slowly, and till the last minute, you're able to adjust the position of the lens in case the lens has been flipped or there's a change in position. Now it goes into the anterior chamber. It's always recommended that you don't try to shoot the lens straight into the posterior chamber, trying to tuck in the haptics of the ICL into the posterior chamber. Instead, it is injected into the anterior chamber. And then the haptics are gently tucked under the iris into the posterior chamber, one at a time. The distal ones go in first, followed by the proximal ones. And this is where the natural position of the lens is. So you need a widely dilated pupil so that you don't have to maneuver the lens. And please note the instrument that is used. It's called a Vukix manipulator. It is not a sharp instrument. It has a sort of a blunt edge, blunt undersurface, which helps it maneuvering the lens without causing it damage, and always touch the haptic, never the optic. Now, suppose you have a toric lens, then after inserting the lens, you need to align the toric lens in the direction of the marks that you have used. Again, the haptic is gently raised using the Vukix manipulator, one end at a time. So you don't dial the lens like you dial an IOL. Instead, because it's plate haptic, you change the position of the lens one at a time, one end of the haptic at a time. Next, you can also use, if you have imaging systems like the Callisto or the Verion, even that can be used to align the toric ICL, just like it's used to align the toric IOL without marking. So this is the marking free alignment of the lens using the Verion. Everything is the same. Only thing, there are two linear marks just below the hole that you see on top. So that indicates the direction in which the lens needs to be aligned. One major difference between the Indian versions of the lens and this one is that the Indian version can be aligned at 180 degrees because the axis is already indicated in the lens. I mean, it's positioned in the lens like you want, whereas the ICL usually needs to be aligned in a particular direction, just like the toric IOL. And it also has a central hole, which is a modification in the ICL. It's been there for the past, I think, around 7 years or so, because initially the ICLs did not have a central hole, and you needed to make a PI for that. But with the presence of the central hole, a PI is not required either before or during the surgery. It can straight away be inserted, and it has never caused an IOP rise because of the lack of flow of aqueous. Whereas in the Indian lenses, because they cannot put the hole in the center, it's a patented thing. So we still need to make the PIs. So the positioning of the lens is behind the iris, the dictum being that it's as far from the endothelium as possible. It gives excellent cosmosis because it's not visible externally. Even if you look under the slit lamp, sometimes you can miss it if you're not looking for an ICL. And it's close to the nodal points of the eye. It causes some gain in retinal size image, and it has a greater effective optic zone at the corneal plane. The presence in the sulcus also makes it stable because now the haptic and those small trims that you saw at the end of the haptic, they sit in the zonules basically. And that's why they're tucked in so well, and they don't rotate by, because of the movement of the pupil. They don't change location because of this particular feature. And it does not adhere to iris tissue. Like I said, there's a small biofilm around it, which prevents any sort of adhesion to the iris tissue. But if the lens vault is high, there can definitely be some pigment coming out of the iris. That is possible. And it does not alter the shape or remove tissue from the cornea, which is a major difference from LASIK. Now, this is the reason. The next slide, this is the one which shows the reason why it's quiet in the posterior chamber. That is because the properties of this particular material, it is so biocompatible that reduces the probability of an inflammation inside the eye. Secondly, this monolayer that is formed of fibronectin around the lens prevents the lens being recognized as a foreign body, because of which an immune reaction is not incited against it. And you can see that even after the first day, other than maybe 1 or 2 pigment cells, you won't find any sort of flare or cells in the anterior chamber unless there has been a lot of maneuvering while inserting the lens. Now, that property makes it suitable even to implant it as a piggyback lens in this kind of a case where you can see that there's a penetrating corneal injury. And now this was a young patient that had a traumatic cataract for which an IOL was implanted. And you can see all the adhesions between the lens capsule and the iris there. And he had a huge cylinder to the tune of around 5 diopters. And because the scar is right in the center, laser ablation was not possible. And because of which an ICL was used as a piggyback lens. Now, what aided the stability of the ICL that there were some adhesions on either side which prevented the rotation of the ICL over the IOL. So it kept it aligned in the direction that was required. And post-operatively, once you wash the visco out very well, there is no formation of any sort of membrane between the 2 interfaces, the 2 pseudophakic interfaces that you see over there. So this is how it is supposed to sit. Now, the most important aspect of the lens is the vaulting of the lens. So there are a couple of parameters that we check post-operatively. One is the clarity of the cornea. So just like in an IOL, we write that the cornea is clear or it has some escape, or we write that the anterior chamber has some cells and flare, and then the position of the PC IOL. Similarly, we start with the cornea in the ICL, the cornea, whether it's clear or not. There's no reason it needs to be unclear. Then the second thing is we measure the anterior chamber depth. So whether it's adequate, I mean, is the lens so highly vaulted that the anterior chamber depth has been reduced a lot by Van Herrick's grading. So we prefer a chamber of 2 or 3, which is what you get if you have sized the lens very well. The next aspect that is noted is whether the pupil is regular. For a good vaulted lens, the pupil will always be regular and it will seamlessly constrict and dilate over the lens, just like the natural lens. Then the aspect you note is whether the ICL is in position and what the vaulting of the ICL is. So vaulting is calculated as the distance between the anterior lens capsule of the natural lens and the posterior surface of the ICL. So that's a very important factor, and that is what leads to all trouble if it is not maintained properly. Normal vault is supposed to be between 200 and 800 microns. Anything less than 200 is considered low vault, though not necessarily dangerous. Anything more than 800 is considered to be high vault. Again, not necessarily dangerous, provided the angle is very wide and the anterior chamber depth is very good. So here are cases where you can see a very low vaulted lens. The one on top is a very low vaulted lens. It is actually much less than 200 microns. We compare the vaulting with the corneal central thickness, central corneal thickness. So you say the lens has a vault of 1 cct or 0.5 cct or 1.5 cct. That is how you assess under the slit lamp, because we may not always have an anterior chamber, anterior segment OCT to measure the vault digitally. The CCT measurements is what we compare it with. And you can see that lens sitting over there is around 100 microns in vault, the one on top. But because it has a clear difference from the lens, at the periphery also it is away from the lens. That is why this is in very low danger of causing cataract, especially because there is a central hole. There is always circulation of the aqueous, and it is in very, very, very low danger of causing cataracts. And in my practice of 12 years with ICL, I'm yet to see a cataract caused because of a low vaulting lens. On the other hand, what you see below there is a very highly vaulted lens. So one thing I'd like you to note is that the highly vaulted lens, it stretches up the iris, it tends up the iris, and that is why it can cause a lot of pigment dispersion. When you have a low vault, the lens is also prone to a lot of movement. So you can see that this lens is actually slightly on the lower side, because as soon as you send some saline with the cannula inside, it starts, shaking in the anterior chamber. So that's an indicator before you come out that's a low vaulted lens. A low vault can also rarely form cataract. Like I said, this is not common. And this cataract was not because of a low vault. This was because of a trauma. So now this rare cataract formation can be dealt with regularly. You can explant the lens and do a cataract surgery and put in the adequate IOL. This patient was a very high myope, -19 diopters, for which the ICL was placed initially. So in this patient, I retained the ICL and did the cataract surgery. Now here the ICL is shifted into the anterior chamber, and there's a lot of viscoelastic between the cornea and the ICL and the ICL and the lens. And because it's a young patient, I didn't need to do much phaco. I could aspirate the lens easily with the coaxial IA. And then that's implantation of a multifocal lens into the capsular bag. And once that is done, the ICL is tucked back into the posterior chamber, not into the capsule, but into the posterior chamber. And the viscoelastic in the interfaces over and under the lenses are taken out. Again, this patient is stable, and now the main reason was that he wanted a multifocal lens, and I couldn't get a multifocal lens below 5. So he's around 32, 34 years of age. He's a teacher by profession, and that was the reason why I retained the ICL and then inserted the multifocal lens. Now, when you have a raised high vault, then the largest danger there is a raised IOP because of zipping of the angle, wherein an open angle goes into a closed angle. So 904 is a very high vault. You can see even larger ones sometimes, especially for beginner surgeons. So that is why it's very important that you consistently measure the white to white yourself and don't let your assistant do that. Now, this is a patient in whom in one eye the lens was vaulting very high. As you can see that the peripheral anterior chamber is very shallow, whereas in the other it was of the ideal size. So this has a danger of causing a lot of pigment dispersion as well as angle closure. And if you ask me which is better, a high vault or a low vault, I definitely go in for a low vault if there's such a choice. Now, what if the lens is high vaulted? This is a lens which was highly vaulted. It was by new surgeon, and that needed to come out of the anterior chamber. So again, like you implant the lens, it's not a frivolous thing, but it can be easily explanted as well. So it needs to be brought back into the anterior chamber from the sulcus, and you can see that from the same opening that the lens was inserted, the lens can be pulled out. It can just be removed like a tissue out of a box. And provided you have maneuvered properly, you have touched the natural lens inadvertently or damaged the iris too much, the eye continues to remain quiet. So to summarize, The basic requirements for a phakic IOL are that it should be biocompatible, it should be able to pass through a very small incision, it should be soft and pliable, non-traumatic to any sort of maneuvering within the eye. It has to be thin enough to occupy the posterior chamber. It should incorporate a wide range of refractive errors and should be non-brittle so that even if it requires to be explanted, there is no danger of the lens having changed its properties. Thank you very much. Any questions or any discussion?
First one is there a orientation which haptic should go initially? I think there's a dot right and initial haptics as a circle. Is it like which direction it should go?
Yeah, so the first thing is that unlike the IOL which folds like this with the concavity facing you, the ICL folds in the opposite direction with the convexity facing you. So that is one major thing. I mean, because we are all familiar with IOLs, that's why I'm comparing. And the dot is a big factor, I think, in the IPCLs basically, because they say you watch out for the dot, whether it's bleeding. But as the lens comes out visually, you will be able to appreciate the way in which it's folded. That's also dot at the haptic of this lens as well.
Right or left that dot?
It's onto the, yeah, it differs. It differs. There are manufacturers that put the dot on the left, there are manufacturers which put the dot on the right. So when the Indian manufacturers wanted to change, because of all this is because of patent rules. So they couldn't put a hole at the center, they put 4 at the periphery, they put 2 at the periphery. Similarly, they couldn't put the dot there, they put the dot here, and that kind of changes something. So it depends on the lens that you're using, but the basic tenet is that it should be convexly folded, and as it exists, you please push it a bit, wait there and watch what's happening. And as it comes out a bit more, just make sure that the haptics are coming out properly. Sometimes one may come out a bit more, the other may take some more time to come. But this is a lens which is not going to come out in a hurry. So you have to push it very slowly. If you really push it, well, it's just going to come out. But we need to push it very slowly until 7/8 of the lens comes out. You'll always be able to stop and change the orientation, which is a big range of possibility of error correction that is being given.
Second question, what is the tolerance for toric? What's the power tolerance in ICLs? Is it more than 1 or when do you look at toric?
Yeah, so usually we combine a sphere with a cylinder in most cases, but I have done pure torics as well. And I have a cutoff of 470 for my LASIK patients. So any cornea that's thinner than that, even if it's a 0.75 cylinder that the patient needs, I don't do a laser on that eye. I don't do an ICL either, but I don't do a laser in that eye. So if you ask me, the smallest I have put is 1.25 diameters of cylinder. But whatever you put, even if you 0.5, it's corrected very well. But yeah, would you like to do an intraocular surgery for that? Is the question.
That question is that things you showed. You did a phaco under the ICL and you put an intraocular lens. So was it the pre-op readings that helped you calculate the IOL power? Because of the ICL there, maybe VA scans and all.
That is the most pertinent question in that whole case. The only question that should be asked. So yeah, the IOL power calculation, if you are retaining an ICL and putting an IOL, whenever we do an IOL power calculation on an A scan, they always ask you a target refraction, which we keep as 0 when we are explanting the lens and putting an IOL. Please remember here the ICL is retained for a patient who had a myopia of -19. So when I put in an IOL under it, my target refraction is going to be -90 because that ICL is still there and it is correcting that residual power that my IOL will produce. So that is how I calculate the power of an IOL.
So the IOL power was how much do you put?
I don't quite remember, but I think it was around 12 or...
You needed so much.
Yeah. I'm not very sure because this happened some time back. So I think it was to that tune. It was definitely much more than 5 and much less than. It was more than 12 if I'm not mistaken.
It would be how the lens fits it.
Yeah.
How much weight was.
Yeah.
Your ICL minus 90 remains the same.
Yeah, exactly. So it was a
Like
part of the
normal
natural lens that I was
natural
trying to,
lens.
yeah, definitely. That's true.
In this case, you could aspirate it. If you really needed phaco energy, will it not damage the ICL?
Yeah, that you have to be very careful in that. But there have been so many reports of the ICL having been retained and a femtolaser having been done and vacoemulsification having been done. It doesn't damage the ICL that easily. It doesn't, though we think it's a very, soft, silky, nice material, but still.
Ma'am, some cases needs bilateral, most cases.
Most.
High myopia. So, you do in single sitting or?
No, I always do in 2 sittings. We treat one eye as, a single eye. Like you do the IOLs, I never do any intraocular surgery unless it's a child under GA or a very incapacitated patient under GA. I don't do any bilateral. Maybe the gap can be very small, less than a week sometimes. And another thing is that once you insert the ICL, like in one patient where I explanted, you can see how the vault is after implanting one. Suppose it was the beginning of your surgical career with the ICL. Then if the vault is high, you can always hold on and keep the other lens away, and you can ask the company to replace the other lens with a smaller size lens. So that when you do the second eye, that vault is perfect, and then you can decide whether you need an explantation in this eye or whether the vault is high but still okay enough to be in the eye. So that is also another thing that happens.
Ma'am, another question is, I have seen one patient with ICL, non-employee, but there is a small pupillary capture in the one of the haptic. But the eye is quiet actually. And so is it indication for explantation? I don't know what I should tell the patient.
Because it is a very unusual phenomenon, because as you saw, the optic nowadays the ICL comes in a 6.1 optic.
But I have seen one patient.
Yeah, so could be that there was some damage to the sphincter in that region when the procedure was done, because of which it's tenting up there. Could be, I don't know, because I have never seen anything being captured, or it could be that, I don't know. I mean, even if you dilate, it comes back just as, normal. But I don't think that would be reason for explantation as such, because it's a cosmetically bad eye under the slit lamp. Nothing mattering to the patient unless there's a lot of glare.
The company replace the lens very possible. Doctor won't explain.
Yeah, that's a dicey thing. You have to have very good relationship with the company to do that. Otherwise, they don't do that.
Is the cost difference big between the Indian companies and
A lot. Earlier, that used to depend on the power. I mean, IPCL is what I know about. It used to depend on the power of the lens. For the star ICLs, it's a flat rate. The cost price to the hospital itself is around 32,000 for a spherical lens and 43,000 for a toric lens.
single lens?
So, but the Indian lenses are not behind. They also cost quite a bit nowadays. Who does ICL over here? I mean, you regularly do it, or are you planning to start ICL surgery?
Planning. The requirements are needed for a perfect eye spacing with the white. Anything more than the biometry, optical biometry.
Optical biometry need basically for the ACD. I use my topographer itself for the ACD.
Subsource OCT
Yeah, why not? Why not? That's very good. Yeah, ACD, you won't be. Only thing you have to keep your rule that you won't go below 2.8 millimeters. That is the lowest ACD you can implant an ICLA. And the other thing is that it has to be taken from the endothelium. Third thing is more important than ACD I found is the white to white. Always.
Is that a calculator?
Yeah, the star ICL does not have an online calculator. You provide data to the company and they calculate it for you. Still, there are some watershed zones like 11.2 millimeters is a watershed white to white zone. What I mean is that if your you have measured the white to white and comes out to be 11.18, so you usually round it off to 11.2, then they will give you a slightly bigger lens. But if your white to white measured is, let's say, 11.11, then still 11.1 rounded off, and you will give they'll give you a 0.5 millimeter smaller lens. All that makes a huge difference to the ward. So if you ask me, I'd try to stay with the smaller lens, even for 11.19. So there are such there are watershed zones like that, which, I mean, if you ask the company, they'll give you a data regarding.